Hello, my name is Tammy Garrett, and we're reporting off on our project, which our project was, this is our project presentation, review and revision of nursing care standards and ICU policies and procedures of non-invasive blood pressure monitoring. The presenters are going to be Tammy Garrett, Crystal Maloney, and Danielle Moore. The current practice right now at Deaconess Hospital is that in the PMP it states that a manual blood pressure be taken on all patients that come into the ICU upon admission and every shift change. That includes any patients that have an arterial line invasive blood pressure monitoring as well as automatic blood pressure monitoring. The way this project came about was that the nurses were handed the policy and procedures to review, and upon reviewing these policy and procedures, it was found that this was a practice that was not being done at the bedside. So the staff asked if this could be removed from the policy. So this is our project. Our project goal is to remove this from the policy and procedure. Upon our research, we found there was no evidence-based practice that supported that a manual blood pressure be checked upon admission and every 8 hours in the ICU. Our clinical group made the proposal to change the policy in every ICU at Deaconess Hospital to eliminate the requirement of the manual blood pressure upon admission and every 8 hours. Our hope is that this change would reduce the unnecessary procedures to reduce some inefficiencies in workflow and to be able to help return direct care to the patients to improve patient and nurse relationships as well as improve patient outcomes. The process in which we do this at Deaconess is that we do research evidence-based practice to see if there is any correlation to doing this procedure or doing this step in blood pressure management, and there was none. We did not find any supporting evidence-based practice that supported doing a manual blood pressure check, along with in correlation with intra-arterial blood pressure and automated blood pressure monitoring. So when no evidence was found supporting this policy, we proposed for a practice change and was presented to the practice council. We passed a survey out. We didn't get a lot of return from the survey, but we did present a survey out to the staff asking questions in regards to what they would prefer, manual blood pressure versus automated blood pressures in their unit, and the staff preferred the automated blood pressures. This being in regards to they do electronic charting and automatic blood pressures, automatic slaved over to the charting. That was the biggest plus for that for them. The continued process was what Donna Cobb, which is the clinical nurse manager, presented this policy change to the practice council. The practice council meets the first Tuesday of every month. And in the practice council, it is nurses from all over the hospital that come and present possible changes and ideas for policy and procedures throughout their practices. So Donna presented this at the practice council as to make a policy change to remove this from the critical care policies. Practice council gave the okay for this to go on to the next step, which is the critical care core team. So Donna took this from critical care core took this from practice council and then presented this proposal to the critical care core team, which meets the third Thursday of every month. Critical care core team consists of physicians, nurses, managers, other ancillary departments, anyone such as respiratory dietary, anyone that would take care of critical care patients. This was brought to the attention of critical care core, this change that was wanting to be made, and critical care core agreed that this should be changed from the policy. So with that in mind, then what happens next is once we get the okay from critical care core, because this affects all critical care teams, then the policy is then rewritten, once it's rewritten, it is sent to the chief nursing officer, and the chief nursing officer reads the policy and okays the policy change. Once that's done, then the staff is then educated on the policy change, and then practices are changed from there.
As for supporting research regarding our project, the American Association of Critical Care Nurses had issued a practice alert regarding non-invasive blood pressure monitoring. The alert focused on the need for accuracy during blood pressure checks, whether the method be oscillatory, oscillometric, or intra-arterial. When comparing the results of manual and automated blood pressure measurements, it was shown that oscillometric systolic blood pressure readings were overestimated by 2.12 millimeters of mercury, and diastolic blood pressure readings were overestimated by 2.36 millimeters of mercury. Statistically, systolic measurements are significantly different when using an oscillometric device as opposed to a manual device. The AACN suggests using one method for blood pressure measurement to improve accuracy, whether it be manual, oscillometric, or intra-arterial. The results of our project, on completion of this project, the Deaconess Hospital ICU policy and procedure of obtaining a manual blood pressure upon admission in every 8 hours was eliminated and replaced with either being obtained through an automated or intra-arterial method. However, if the required blood pressure reading does not match the patient's clinical profile, a manual blood pressure or Doppler should be obtained as a second check.